Hello. Thank you for attending this international virtual symposium organized by INSET. Today, I will be talking about ovarian stimulation for cancer patients for the purpose of fertility preservation. Cancer remains a public health problem worldwide that also affects young adults. Given the ongoing improvements in survival for most malignancies, a significant proportion of people affected by cancer face the consequences of treatment-related side effects. Therefore, at the time of diagnosis, a significant proportion of young patients are concerned about the possible impact of anti-cancer treatments on their infertility, on their future fertility, and future chances of having a baby. So today I would like to discuss oncofertility counseling for cancer patients, oocyte cryopreservation for the purpose of having a baby in the future, standard versus alternative controlled ovarian stimulation protocols in cancer patients, and finally, the impact of pregnancy and controlled ovarian stimulation on the overall survival and recurrence-free survival rates in cancer patients. So all cancer patients of reproductive age should receive a complete oncofertility counseling as early as possible in the treatment planning process. And this is regardless of the type and the stage of the disease. So first of all, the oncologist should discuss with the patient the gonadotoxicity of the planned anti-cancer treatment, taking into consideration the patient's age and the ovarian reserve markers, and that way determine the patient's particular risk of ovarian insufficiency after treatment. Premature ovarian insufficiency is defined by the loss of ovarian function, and it's indicated by the presence of amenorrhea or oligomenorrhea for more than 4 to 6 months, together with biochemical markers confirming ovarian insufficiency, such as a high FSH and a low estradiol level for at least 2 times, at least 4 weeks apart in women before the age of 40. However, after cancer treatment, many patients experiment temporary amenorrhea that usually reverts in the first 12 months, sometimes even 24 months after gonadotoxic therapy. However, some patients will enter permanent amenorrhea. Regardless of whether this amenorrhea is permanent or temporary, all patients will have a diminished ovarian reserve compared to pre-treatment parameters, and all will have an increased risk of having a premature menopause. So ovarian insufficiency, the risk of ovarian insufficiency after gonadotoxic treatment is classified in 4 groups. Some cancer treatments have no known effect on the ovaries or the gonads. Other anti-cancer treatments are considered low risk, and that means less than 20% chance of having a premature ovarian insufficiency. When the risk is between 20 and 80%, the risk is considered medium, and when this risk is above 80%, the risk is considered to be high. And this will depend on the combined effect of factors such as the woman's age and the baseline ovarian reserve, her diagnosis, and the treatment protocol. That includes not only the cumulative dose of whatever treatment is chosen and the overlapping therapies over a given time period. So once the doctor, the oncologist, has discussed with the patient her individual risk of ovarian insufficiency, he must discuss with the patient her current or future fertility desire, regardless, again, of the type and the rate of cancer. And all those patients with a potential interest in fertility preservation should be referred immediately to a fertility specialist or a fertility clinic in order to define and proceed with a fertility preservation strategy. Both oocyte or embryo cryopreservation are clinically validated techniques with very reproducible cryosurvival and pregnancy rate in post-pubertal females. This technique cannot be applied to children before puberty. However, oocyte cryopreservation does have some advantages over embryo cryopreservation because it does not require a partner, and this can be an important issue for women without a husband or a committed partner who do not wish to use donor sperm. And also, it is associated with less legal or ethical dilemmas over the disposal in the future of unused orphaned embryos. However, both oocyte and embryo cryopreservation require controlled ovarian stimulation, and the classic controlled ovarian stimulations imply the administration of gonadotropins on a daily basis as of day 2 or 3 of the menstrual cycle, followed by the co-administration of GnRH analog in order to suppress the LH surge, and finally a trigger shot to induce oocyte maturation once the leading follicles are around 18 or 20 millimeters in diameter. This whole process usually takes around 12 to 14 days, that is around 2 weeks. And the whole idea is to promote the growth of not just one follicle, as is the case in a natural cycle, but the growth of at least 12 or 15 oocytes, if possible, even 20 oocytes. The more, the better, up to a given point. And that is because age and ovarian reserve are determining factors for success. In other words, age affects quality, and the ovarian reserve, the ovarian response, or the amount of oocytes that can be retrieved. This retrospective multi-center study of vitrification cycles for fertility preservation for various reasons, and on the warming cycles of the women who returned to attempt pregnancy over an 11-year period, using this Kaplan-Meier plot of cumulative probability of live birth, shows that the possibility of a critical live birth is basically the same regardless of the indication for fertility preservation. In the blue curve, we see patients that cryopreserve because of they wish to have what we call an elective fertility preservation process, or just planned fertility preservation process without a real clinical indication. And in red, we have patients that had fertility preservations because they had endometriosis of the ovaries. And then in the green curve, we have the patients that cryopreserve because of cancer reasons. We can see that given the use of a similar amount of oocytes in women categorized according to age, the probability of having a baby over time is basically the same for the three same groups. That is, if a woman thaws around 10 oocytes, the probability of having a baby would be around 40%. But if these young women actually can use up to 20 oocytes, then the probability of having a baby over time would be around 80%. However, in women over the age of 35, that is 36 and over, the probability of having a baby after thawing 10 eggs would only be around 25%, and after the thawing 20 eggs, the probability would only be around 60%. Therefore, age is a very important parameter with regards not only to oocyte survival, but the probability or cumulative live birth rate over time. Classic ovarian stimulation protocols, as the one we just discussed, are associated with elevated estradiol levels. This can be up to 10 to 20 times higher than that of a natural cycle. Also, a possible delay of even 4 weeks to start the ovarian stimulation process, depending on the day of the menstrual cycle that the patient first consults. Therefore, having to wait sometimes 3 or 4 weeks till the second or third day of the next menstrual cycle. And finally, there can be an additional delay of around 2 weeks in case of ovarian hyperstimulation syndrome, that is a very high response where we would have to wait for the ovaries to shrink back to their original size before starting the cancer treatment. These can be especially troublesome for young women with breast cancer. Breast cancer is the most commonly diagnosed cancer in young adults aged 30 to 39 years. About 10% of breast cancer diagnoses are in women under the age of 45. And about 2/3 or 2 out of 3 breast cancers are hormone receptor positive. In other words, for these women, having the high estradiol levels associated with ovarian stimulation can be quite troublesome because of the fear that these cancer cells might proliferate under the effect of estrogens. Also, hormone receptor positive cancer patients usually undergo what we call endocrine adjuvant therapy after surgical removal of the tumor during 5 to 10 years. And this will be an additional age-related decline in the ovarian reserve, in addition to the gonadotoxicity of whatever treatment was used. Finally, nowadays, neoadjuvant therapy, that is chemotherapy before the surgical removal of the tumor, is being extended to localize the disease, especially in young triple negative or HER2 early breast cancer patients, and occasionally as well around 6% of hormone receptor positive early breast cancer patients. So these are issues to consider when thinking about fertility preservation in these breast cancer patients. Finally, about 12% of young breast cancer patients carry a germ-like pathogenic variant called BRCA1 or BRCA2. These patients require additional counseling due to the negative impact on ovarian reserve and the fertility potential, increased risk of ovarian cancer, and even having sometimes to consider risk-reducing bilateral salpingo oophorectomy at a young age. And finally, the possible transmission of the pathogenic variant to the offspring. So it is the need to design alternative controlled ovarian stimulation protocols adjusted to the needs of these young cancer patients was evident. One such alternative or protocol considers the co-administration of aromatase or SERMs along with the gonadotropins during the ovarian stimulation process, with the idea of either reducing the estrogen levels, in the case of aromatase inhibitors, to concentrations similar to that of natural cycles, or the use of SERMs such as tamoxifen in order to block the effect of estrogens at the breast receptors. A recent meta-analysis, including 11 cohort studies and over 2,000 women, comparing the safety and the efficacy of controlled ovarian stimulation with or without letrozole for fertility preservation purposes, where the primary endpoint was the number of mature oocytes retrieved, observed that the addition of letrozole to controlled ovarian stimulation was associated with a significant decrease in the peak estradiol level, but with no impact at all on the number of mature oocytes retrieved, as we can see in this meta view here, with a mean ratio of 1. Also, 2 recent randomized trials compared the effect of tamoxifen or letrozole on the number of mature oocytes retrieved compared to the standard ovarian stimulation protocols. In the first of these randomized studies is a single institution study that included 96 women with estrogen receptor positive breast cancer that were randomized to two treatment groups, one receiving standard controlled ovarian stimulation plus 20 milligrams of tamoxifen, and the other group with the addition, instead of tamoxifen, of letrozole 5 milligrams. The results were compared to those of a group of patients with estrogen receptor negative breast cancer undergoing standard controlled ovarian stimulation. And the second is a multi-center randomized trial that included 162 women with breast cancer, regardless of the estrogen receptor sensitivity, that were randomly assigned to three groups. One in which tamoxifen 60 milligrams was added to the controlled ovarian stimulation. A second group had letrozole 5 milligrams added to the standard stimulation process. And the third group just received the standard stimulation with 225 units of FSH under a GnRH antagonist protocol. And what the two studies showed is that there was no difference in the mean number of mature oocytes retrieved in the three, when comparing the three groups. And finally, what is very interesting is that the peak estradiol level was significantly lower in the group that received controlled ovarian stimulation with letrozole group. That is, in both studies, the mean estradiol level for this group was 642 picograms per ml compared to 2,500 for the tamoxifen and the standard group. And very similar results were found in the second study, where the estradiol levels were 490 picograms compared to 1,662 and 1,546 for the tamoxifen and the standard stimulation groups. The second ovarian stimulation alternative protocol is what we call random start protocols, where the stimulation process is initiated immediately after the patient's consultation. And this contrasts with this conventional start, where the gonadotropins are only started on the second or third day after withdrawal bleeding or the menstrual cycle. In random start cycles, then gonadotropins are started after the initial visit, regardless of whether the patient is in the late follicular phase, that is phase 5, 6, or 7 of the menstrual cycle, or 10, or in the late or in the luteal phase after ovulation. It's always 2 or 3 days after the patient's initial visit. And what this systematic review and meta-analysis of 10 studies shows, that was recently published and that included 1,653 cancer patients with the purpose of comparing the clinical outcome of random versus conventional start protocols, is that overall the random start cycles were longer, with a mean difference of 0.7 days, used more gonadotropins with a mean difference of 248 units than standard controlled or ovarian stimulation cycles. However, there was no difference among the two groups in the number of mature oocytes retrieved and in the number of cryopreserved embryos. In other words, they're both clinically comparable, except for being the random start being at 1 day or less than 1 day longer. And finally, the third alternative ovarian stimulation protocols administer progestins instead of GnRH antagonists to prevent the premature LH surge. This is basically a cost-reducing strategy, I would say, and also used always GnRH analogs to trigger oocyte maturation instead of using ACG in order to prevent ovarian hyperstimulation syndrome, which would delay the start of anti-cancer treatment. So finally, I would like to review a couple of recent studies evaluating the safety of pregnancy and the alternative controlled ovarian stimulation protocols after breast cancer regarding the time to initiate cancer therapy, the disease-free survival, and the overall survival of these patients. So this review published this year by the European Society of Medical Oncology that included 3 matched cohort studies evaluating the time to start NAT or neoadjuvant therapy in hormone receptor positive breast cancer patients, observed that only one of the 3 studies reported a significantly but very small delay of 10 days to start NAT in the cohort study undergoing ovarian stimulation compared to the control groups. The authors consider that this delay, if any, is modest and clinically trivial. They also included 6 cohort studies assessing the survival outcomes in these patients, and they observed no increased risk of recurrence or death after a follow-up period that ranged between 3.5 to 6.9 years in the different studies after controlled ovarian stimulation in women referred to NAT or with hormone receptor positive breast cancer. There was no data on the safety of controlled ovarian stimulation in patients that were both hormone receptor positive or undergoing NAT. So the authors again conclude that the being referred to neoadjuvant therapy or having a hormone receptor positive breast cancer does not constitute per se an a priori contraindication to control ovarian stimulation in women with early breast cancer patients. And what about the safety of pregnancy in these women with hormone receptor positive disease? And this meta-analysis included 8 retrospective cohort studies comparing survival with and without pregnancy in premenopausal breast cancer patients with hormone receptor positive disease. After a median follow-up of 3.8 to 15.8 years, in which 33% of the patients included had a subsequent pregnancy and 66% had no pregnancy, the results show that there's no difference, as we can see in the meta-views, in the disease-free survival between the groups. According to 3 studies that included 987 patients with a hazard ratio of 0.96 for the disease-free survival. And however, which is quite interesting, there was a significantly better overall survival in the group with a subsequent pregnancy, according to a meta-analysis of 6 studies in 3,500 for patients with a pooled hazard ratio of 0.46. So this is quite promising, I would say. And with regards of pregnancy in breast cancer patients who are carriers of the pathogenic BRCA variant, this multi-center retrospective cohort study conducted in 78 participant centers worldwide in women aged 40 years or younger who had invasive breast cancer, carrying the variants either BRCA1 or BRCA2, in order to investigate the cumulative incidence of pregnancy and disease-free survival in these young women, observed that 659 out of 4,732 patients, that is 14% participants, had at least one pregnancy after a median of 3.5 years after the diagnosis of breast cancer. And there was no difference in the disease-free survival between the patients with or without a pregnancy, with an adjusted hazard ratio of 0.99 after a median follow-up period of 7.8 years. And again, the patients who had a pregnancy had a significantly better overall survival. So no negative effect was associated to pregnancy in this subgroup of breast cancer patients either. This same study group also evaluated the safety of doing controlled ovarian stimulation and IVF to achieve a pregnancy versus natural conception in this subset of breast cancer patients who were carriers of the BRCA gene, and observed that out of 543 patients who had a pregnancy, 80% after natural conception and 20% after IVF, there was no difference in the disease-free survival between the two groups after a mean follow-up of 9.1 years. So neither IVF nor pregnancy were associated with an increased risk of recurrence or death. Finally, I would like to review this trial called the POSITIVE trial that was recently published in the New England Journal of Medicine, which stands for Pregnancy Outcome and Safety of Interrupting Therapy for Women with Endocrine Responsive Breast Cancer Trial. This is an international, multi-center, prospective trial conducted by the International Breast Cancer Study Group in 20 countries around the world. And it was designed to evaluate the safety of interrupting endocrine therapy after breast cancer, and it included patients aged 42 years or younger with breast cancer stages 1 to 3 who received adjuvant endocrine therapy for at least 18 to 30 months and discontinued the therapy for only a maximum of 2 years in order to expose themselves to a pregnancy, carry out the pregnancy, and breastfeed. And the results are that out of a total of 518 patients who discontinued this endocrine adjuvant therapy after a mean time of 29 months after cancer diagnosis, the cumulative incidence of breast cancer-related events was 8.9 and 9.2% in the endocrine treatment interruption group versus the extended control group after a 3.4 years of follow-up. So there was no evidence of any detrimental effect of interrupting the temporary interruption of the endocrine therapy. And they also decided to evaluate whether undergoing controlled ovarian stimulation and IVF in this same cohort of patients would affect survival. And what they found is that after interrupting the endocrine therapy, 497 cancer patients resumed menses within 12 months. And out of these, 179 patients that had undergone controlled ovarian stimulation and fertility preservation at the time of cancer diagnosis, 68 had a subsequent embryo transfer. And the cumulative 3-year incidence of breast cancer-related events after discontinuing this adjuvant endocrine therapy was similar between the group of patients who underwent controlled ovarian stimulation or not. And finally, out of 368 patients who reported a pregnancy, it was evident that those who underwent fertility preservation and embryo transfer had a much higher conception rate with an odds ratio of 2.41. So I would like to conclude by saying that despite the general perception of iatrogenic infertility as one of the major concerns among young breast cancer patients, the number of those seeking fertility preservation before undergoing systemic cancer therapy is very low, around 10%. And so what we do need to do is to generate awareness about the risk of premature ovarian insufficiency after anti-cancer treatment and the feasibility and the safety of fertility preservation in young post-pubertal patients with cancer, especially breast cancer stages 1 to 3. An efficient network then between the oncologist and the fertility unit must be established in order to initiate these fertility preservation treatments in a prompt manner. Thank you for your attendance.